So I'm giving a talk today about CD19 CAR T-cells with a particular focus on the hive of activity that's going on in the USA. And what I'm going to try and do is give an overview of the field so that it can be put into context for people as they listen to individual speakers who will be also speaking at this meeting on their successes with CD19 CAR T-cells. I think what we're seeing now through multiple studies at many different institutions and now in sort of cooperative group settings, that for ALL the response rates are in the order of 90% with CAR T-cells. And this is truly remarkable when you consider that the patient population that is being targeted for these sorts of novel therapies is really relapsed refractory who have few, if any, other therapeutic options. I think what we're grappling with for ALL as we now broaden applicability in the US beyond the boutique centres that developed these strategies is, do we really know what attributes of the CAR that we need? Do we want a CAR that sticks around forever in these patients, or do we want a CAR that does its job and then no longer persists so that you then get your B cells back and you're not left with lifelong immune deficiencies? And then the question is, do we know if CAR T-cells actually cure ALL, or should it always be used as a bridge to transplant? And I think in the US, now that there is so much pharma interest in these sorts of agents, this will be a very interesting question, especially when you try and compare the cost of a CAR T-cell versus the cost of a transplant. And if you want to replace CAR T-cells for transplant, obviously this will be something that will be important to address, and so my talk is going to focus on these sort of economic issues as well. I think it's a little different in the lymphoma CLL setting. In that setting, across the studies, the response rates are in the order of 50%, and that's CR and partial remission. So probably of that 50%, about a third to 2/3 achieve a complete remission. But when you compare that to some of the other novel therapies such as ibrutinib, checkpoint inhibitors, this also is looking highly competitive. And I think the next question here in the States for CLL and non-Hodgkin's lymphoma is, what can we actually combine with the CAR T-cell approach? So what other immunomodulators could we use? And certainly the checkpoint inhibitors are an important agent to investigate, and certainly our field is very interested in combining both approaches. And so I think in that setting, can we improve on the efficacy, and can we, as we do that, still limit the toxicities, which overall do not seem to be as brisk as in the ALL setting, certainly from a neurotoxicity viewpoint. So I think it's really exciting at the moment in the United States. There's over 20 open trials for CAR T-cells, CD19 CAR T-cells, and so we really are at a turning point to move beyond just phase 1 studies and really move into multi-center advanced phase clinical trials.